Hello, and welcome to the podcast series Unshakable Strength, Empowering Black Women, sponsored by the Empower Project. The Empower Project is a partnership between Howard University and Health HIV, sponsored by the PACE grant from Gilead Sciences. Girlfriend's podcast miniseries, Unshakable Strength, Empowering Black Women, is dedicated to addressing the unique health challenges faced by Black women and girls, particularly in the context of HIV prevention. We will explore important topics such as sexual health, mental well-being, access to healthcare, and strategies for HIV prevention tailored to the needs of Black women and girls. Today's episode, Empower Her, Meeting Black Women Where They Are, will delve into the vital conversation of health HIV prevention tailored for Black women. Through expert insight, personal stories, and practical advice, our guest, Dr. Monique Howard, aims to empower Black women with the knowledge and tools they need to protect their health and well-being. Dr. Howard, I am familiar with you. I'm going to give you an opportunity to introduce yourself, but I do know that you have 20 years of history in protecting and improving the health and well-being of families and communities around health HIV. When you get a moment, I would love to hear more about that. And we also have Harona Sharif, who is a freshman biology major with the pre-med track at Howard University. She is from the Bay Area, California, by way of Ethiopia. As someone who plans to attend medical school, she is always looking for ways to better inform herself and become a well-rounded, educated person regarding healthcare, especially for the future of Black female physicians. So before we begin, Dr. Howard, please tell us why you do this work. What brought
Sure,
you this work?
sure. Thank you very much for allowing me to be part of this today. Talking about HIV in women is very important, and has been important to me and always will be. I currently am the Senior Director of Women's Health Initiatives and Community Engagement at University of Pennsylvania School of Nursing. I've been working in the field of HIV, as you said, for 20 years. It feels like a lifetime. And as I said, women carry the burden for so many things. And for so many years, women have been underreported and not counted when it comes to HIV and HIV incidence and rates. And so that means prevention messages aren't specific or targeted for us. And that means that care and treatment isn't targeted for us also. So I do the work because people still don't know the work needs to be done.
Mhm. All right. Thank you. So that just kind of leads me to my first question that I'd like to open it up for discussion. And that is, why does HIV stigma persist nearly 4 decades after after HIV kind of came on the scene?
Mhm.
It's still considered an epidemic. So why, after 40 years almost, are we still having the same conversation and how it impacts Black and Brown communities?
Sure. I was just on a panel talking about HIV in women maybe about 2 or 3 months ago. And I asked the same question because I was angry that I'm still on a panel 40 years later. And so what happens is this: women contract HIV generally through sexual contact, right? Unprotected sex with someone that's infected. We don't like to talk about sex. It makes us feel very uncomfortable. It's a sensitive topic. I can't figure out why. We got here because somebody did the act. It brings so much joy when all the stars align and the person is the right person or the people are the right people, right? And so we still the stigma that's associated with HIV is born from the stigma that we have around talking about sex. And so if we can't talk about sex, the good, the bad, the ugly, then we will not be able to talk about anything that is a consequence, good or bad, of sex. And so we can't even talk about a pregnancy, how, right? How we got pregnant. Ooh, let me tell you about it that night, right? You can only say, yes, I'm pregnant. So even in pregnancy, and generally the outcome of the pregnancy, outcome of the sex in that instance is pregnancy, and the majority of the time we're happy about it. Sometimes there's a surprise, but we can't even still get specific. And so HIV kind of bears the burden of the stigma associated with sex and sexual behavior and comfort.
Thank you. Thank you for that. So that kind of leads me into um, kind of like expanding on that information that you've provided. So what are some of the systemic factors that continue to drive the disproportionate impact of HIV around Black and Brown women?
We don't, since we can't talk about sex,
Mm-hmm.
then we don't learn negotiation. We don't learn how to negotiate sexual behavior in the way that, we still think that that level of negotiation is very gendered, and that historically women aren't the ones that are negotiating. And so we don't learn how those really strong negotiation skills, right? That's why women, some women generalized, oh, I don't like to go buy a car because, right, the negotiation that goes on there. So there's that. We don't really teach strong negotiation skills. We don't see that as a female characteristic. Other spaces are healthcare access, right? There's a challenge, particularly in marginalized communities, around access to health, access to quality.
Yes.
Okay, um, quality healthcare, where your practitioner has more than 3 minutes, where you have a relationship and rapport with a practitioner, where you can have conversations about behavior, and where you can receive education. Prevention messages also are geared or targeted toward women of color. Because if the stigma is there, then you don't think you need to, whoever they are, right? Whoever the marketing people are, don't need to target prevention messages to women because women aren't the ones that are at risk, right? I think that there's an overarching belief still of who contracts HIV, and women haven't risen to a level where they're focused upon.
Thank you. Harona, do you want to ask any questions of Dr. Howard?
Yeah, speaking of like unequal ha access to healthcare, it's
Mhm,
just historically known that Black people are commonly mistreated when going to the doctors. They're
mhm.
not, their words aren't taken at face value, they're not respected, and they're not given the care that they deserve. So, how does discriminant unequal access to healthcare impact the prevalence of HIV among Black women?
Our medical facilities aren't always safe spaces. Um, there's a history of why they're not safe. And not only is there history, we can go back to Tuskegee, we can go back to slavery, we can go back. We can also come forward. I think COVID was really, really eye-opening, and really disclosed some of the disparate healthcare. So what happens is if that's not a safe place for you, then you don't go get any of the HIV antibody testing, and you don't find out about your diagnosis early enough, where your options for treatment are wider or broader. And that's not just HIV, that's everything across everything, right? It's breast cancer and ovarian, it's all the preventative methods. We People of color don't utilize them because our healthcare facilities aren't safe, because of the unconscious bias that exists in our
Mhm.
facilities, because our cultural incompetence that exists in our healthcare facilities. We don't go. And think about it. Why are you going to get up, get dressed, travel across town? That might be a couple buses, that might be a subway, that might be a half a mile walk, to be treated poorly when you get there. And so, because of all of the life burdens that women of color endure, our individual medical care, we back burner it. And I'll tell you a story. I remember I have two children and a spouse. And I remember sitting at my computer, the phone, and I made sure everybody had an appointment. Dentist, primary, everybody got an appointment. I felt so incredibly accomplished. I made not one appointment for myself because my responsibility at that moment was making sure my family was okay. And the healthcare piece and the self-care piece is making sure that you're okay so that you can make sure everybody else is okay, right? They tell you that on the airplane. Put the mask on yourself first before you have to put the oxygen mask on somebody else. We don't do that very well. So it's a couple of things. It's uh, our competing priorities, and it's treatment at the healthcare facility that prevent us from getting the necessary tests and the early diagnosis so that we have a lot of treatment options.
Thank you. So, Harona, what are your thoughts about what Dr. Howard is saying?
I honestly couldn't agree more. I'm just a college student, I don't have kids asking me to take them to soccer practice or anything, or a spouse to tend to, or a relationship to cater to. So just learning how to take care of myself as a freshman in college, looking at, how other people were raised versus how I was raised, the relationship they have had with their primary care physicians, how they've been regularly going to the dentist, or if they have never been to the dentist in their life, just small things, noticing how even though we're all Black students at an HBCU, there's so many different things that impact us in separate ways, whether it's our upbringing, where our parents came from, where our family stayed in, what states we're from, what side of the US. And it just really opens up my eyes to see. I was definitely blessed enough to have a really good relationship with my primary care physician. I always felt comfortable sharing anything with her. I never thought for a second that she would take something I said and not believe what I'm saying. She wouldn't truly have my best interests at heart. And I truthfully didn't know that it was such a big dilemma why the Black mortality rate was so high versus the mortality rate for, any other race, until I read in my freshman year of high school, The Immortal Life of Henrietta Lacks, and learning how she was like completely mistreated. Her family lived in horrible conditions. They inherited a bunch of, ailments as a result of their upbringing because of how their family was treated by the healthcare providers. And so just to be here, to be talking about this, to be learning from a professional like Dr. Howard and being able to get all this information is like truly a blessing and a gift. And I'm trying very hard, like in my freshman year of college, while I'm adjusting and acclimating myself to a new lifestyle, to take the time to educate myself, but also count my blessings and know what my privileges are and appreciate those. So this has been a very insightful conversation so far.
And it's really interesting that you brought up Henrietta Lacks, because her family did not benefit from the medical research that we've all benefited from, right? And so, I really appreciate you bringing that up. So speaking of your privilege, right? Was it difficult for you to kind of like navigate your way through being away from home as a freshman, right? Just trying to navigate your way through your medical, like your doctor's appointments, and now that you don't have your parents, now that you're adulting, right? Navigating your way through the healthcare system on campus or beyond. How has that been for you? How have you experienced like medical treatment since you've been away from home?
Fortunately, I haven't had any serious ailments that have required me to seek any kind of medical attention. But I know from just my friends what they've told me, like having a cough or anything, being a little bit unsure of like what your health status is and just wanting to confirm that. It can take like hours just sitting in the urgent care. You don't know if you're going to get even quality care after waiting for so long. And we obviously don't have cars here because DC is just like a very public transport reliant area. So my friends are taking buses to get to this location. Who knows if they're going to get the care they deserve, how long they're waiting, how much of their day they're dedicating. And they knew that it would take that long. Like my friend told me that she dedicated her whole Saturday to like going to urgent care and trying to get the care that she needed, even though she scheduled an appointment and did everything she was supposed to do on her end,
Mm-hmm.
which was really frustrating and hard to hear.
Mm-hmm.
But it's just the way things are right now until we can, make a better difference or a more impactful difference. But just personally, as I felt like I can feel my wisdom teeth coming in, and I'm wondering like what should I do? Should I go to my dentist here? Should I wait till I go back home? Like, I mean, I don't know these doctors very well. I know there's a dentist school at Howard that is always looking for more patients so that their students can get more practice. And there's definitely a lot of opportunities for me, but I just always have that fear of going outside of what I know because my family's been going to the same dentist for years. Me and my sister went to the same pediatrician. So just that sense of familiarity and knowing I'm not going to be taken advantage of, that I'm going to be listened to, not knowing if I'll be able to find that elsewhere, just being so far away from home, like on a completely different coast, but also in a new environment. And I'm going to have to do that like for the rest of my life, keep finding doctors that I can trust, keep finding, a gynecologist, a hospital that I can rely on, my health insurance, trying to figure that out and navigate that is a little bit scary, but I know that there's a lot of resources out there that can assist me in this. But I can never, there's always a question in the back of my head, like, is the doctor going to listen to me the way I want to be listened to? Or are they going to hear my concerns? Am I going to receive the right care? Am I going to get the same treatment as, a white counterpart would? But I try to silence those voices and advocate for myself best as I can to avoid running into those issues.
Thank
And
you.
I think that that's the key, right? The advocacy piece. Because we have limited experience, limited quality experiences with healthcare, we we pass down a messaging around, I don't know, like taking what they say, taking that treatment. You're not smart enough. They're not even speaking the same English you speak. And I tell people, like, we negotiate our cell phone bills, we negotiate. I mean, it is nothing like being in a store and department store, and you stand there online, and you have not been charged the right percentage off on a sale item. And man, to watch the negotiation that goes on, and with the assertiveness and the forcefulness. Oh no, you're going to go back and you're going to look at that sign because that sign says 25% off. And we don't do that for healthcare.
Mm-hmm.
When we get into that doctor's office and that person, or our provider's office, and that person comes in, it's a stethoscope and a white coat. Oh, yes, sure, sure, yes. And we just totally change personalities. And it's practice, right? And it's also recognizing privilege. Like I in healthcare and health insurance, and what type of health insurance you have also allows that to happen. If you have a health insurance that doesn't have as many medical doctor options for you or practitioner options, then you're limited. But all in all, you can still stand up for yourself. And I think that that's part of the training, is standing up for yourself. And I remember going to the doctor and I was like, I want all the tests, all of them, right? To my gynecologist. And that was like code. All of them? Yes, all of them. Because my doctors feel uncomfortable with talking to me about HIV, but we had a code. Why do we have a code? I have no idea. So then he would go. That was when the blood draw was in the office, and the doctor would look at the phlebotomist and say, she wants all of the tests, all of them. And I was like, what is going on? I need the purple top blood tube. I'm going for HIV. And it was like, and it shouldn't have to be that way, but I made sure that I advocated for myself so that I can get the tests that I need and the information that I needed.
That's really interesting. So I would like to know, so how does the history of like medical mistrust or mistrust between the doctors and the Black community play a role in like clinical studies, HIV testing and research around Black and Brown HIV patients, right? So yeah, just kind of walk me through
Sure.
that.
So women weren't included in clinical trials to begin with because of, birthing. So because of birthing and hormones, right? And the impact that the drug may have on an unborn child. and reproduction. And so, women from 25 to whatever weren't included. So that means that medication that are specific for women undoubtedly weren't tested on women. Put a little thought into that when you take your, oh, I've got cramps, let me take some Pamprin or whatever. Like, just put a little thought into that the next time. That wasn't tested on a woman to see if it works. Over the last couple of years, there's been an increase of Black women in clinical trials for HIV meds, right? Because there's been an effort to of inclusion, but the mistrust is there, and even if you weren't there, right? So my mistrust that I received passed down from parents is Tuskegee, right? I was alive and well when they broke the Tuskegee case. That was in 76 when they broke it, right? I was alive and well. I won't tell you how old it was, but I'll tell you I was here. And that was big. That was decades of men who had syphilis not being treated and followed, right? That was years. So even when the medication was available, penicillin, they were not given the penicillin. Let's watch this till the end and see how the death how this plays out, and if the death from syphilis in Black men is different than white men. But the white men didn't die because they were given penicillin. So right there, right? And it means that the women that they were having or anyone else they were having sexual relations with contracted HIV. Syphilis. That means that the children, right? Syphilis passes from the mother across the barrier to the child, right? So the children were born with syphilis, and they weren't treated all the way up the line, right? And so 76 is not that long ago. There may be a great grandchild of a person that was part of this study still, who has a story to tell. And we saw that with COVID. Like, think of all the mistrust that happened, that we've been doing mRNA research for years. But when that vaccine came out, people were extraordinarily skeptical. And in Philadelphia, they were given the vaccination was given to prisoners still first to see if it worked. So nothing's changed with using and we know the majority of the men in prison are men of color. So nothing has changed with using populations that are sheltered in place, right? And experimenting. So that level of experimentation hasn't ended yet. And so what do you do with that information when you hear it? You are less likely to stand in line to be the next experiment. Thankfully, years ago, probably mid 2000s, I'm thinking like between 7 and 10, there was a drug that was in clinical trials that they discovered really quickly that it wasn't working, and they stopped and they stopped it. But what happens if they didn't stop it? Do we know that if they were all stopped when it was discovered that it wasn't working in the way, right? Do we get that honest information? And because of the history, we don't know, right? We don't read those heavy, deep medical journals that come out. Like, that's not next to, the newspaper, right? That's a specialty. So we're not getting the information that we need, and that mistrust, it continues to grow. And so there was great distrust in the government with clinical trials, with testing. So I don't know if those numbers change. I don't know. There's efforts, but I don't know how you build that trust.
So right now, what do you think the level of participation in clinical trials is for Black and Brown women?
Sure. I just read a piece of data that says for every 10 white women that are in a clinical trials, one is Black. Every 10 people, one of them is Black woman. So that's, was that 1%? That's 1%. That's low. And that's after targeted effort.
Wow.
So I don't, yeah, I don't know. I mean, that's going to call for lots of conversations with communities, lots of conversations with women. It's also going to call for, now that's systemic change, right? Because we have to trust that we're going to be treated fairly across the board. So if you don't listen to me in the doctor's office, what would make me think you're going to listen to me in a clinical trial?
Mm-hmm.
Right? And so that we have to change the entire culture of the healthcare system.
Mm-hmm. So would you say that that is one of the barriers for participation right here and right now with Black women in clinical trials?
Sure. If we aren't listening to Black women who've birthed a child to say, "Ooh,
Something's not
something
right.
doesn't feel right.
Mm-hmm.
Something's not right. I have a no. Oh, she died. You are not supposed to die in childbirth.
Right,
You are
right.
supposed to birth a baby. You're supposed to have sore nipples. You're supposed to leave the hospital weighing a little less than when you walked in,
Right.
very much alive."
Mm-hmm.
And so if you're not listening to that, then and that's it, like the system, right? If still those issues that prevent people from going to get preventative testing don't change,
Mm-hmm.
right? Then I don't see where the number of people of color are going to increase at clinical trial.
Right.
I actually had a question. As a college student, on a college campus with a lot of people between, 18, early 20s, what would you recommend as a way to change the culture? Because at my high school, to improve like people getting cavities and things like that, they would bring trucks where they would have like on campus,
Mm-hmm.
teeth cleanings and stuff like that, or more informative things to raise awareness. What would you recommend for a college campus for something like HIV,
Sure.
changing the culture around it for prevention?
I was going to ask you a similar question. You, Harona, Dr. Harona, have to start a movement, right, around normalizing conversations around about HIV, about reducing the stigma.
Mm-hmm.
And you have to start talking about it all the time and talking about sex. Not this is what I did, but sex and sexual behavior and condom use and female condom and whatever. And then bring people on campus to talk about HIV, HIV in women, HIV in relationships, HIV in trans communities, HIV. And because the rates are high, because people are still dying, because it is still extremely important to talk about it.
Mm-hmm.
And we're not. It's not, I don't think that your age group, I have a daughter in high school and a daughter in college, right? She's a sophomore, second year. And it's only because I talk about it that they know about it. Nowhere in their life is anyone talking about HIV except for me, the crazy lady, the sexy lady, right?
Next lady, yeah.
The sexy lady. It used to be the condom lady. When I was at a club with some young kids and I just gave out condoms too early in the day while we were in the same club. Something is just wrong with that, right? And here I hear, is that the condom lady? I was like, seriously, we're why? First of all, again, why are we in the same club together? And secondly, is there nothing else you could have called me? The condom lady's here, and then everybody turned around. But you got to turn into the condom lady. You have to turn into the, oh, I have something for you, or I have something for you,
Mm-hmm.
and make it something that's not the sensitive topic that it is. We could talk about cancer, we could talk about the cold, we could talk about COVID, then we should be able to and have to be able to talk about HIV because
And I
that's how
think,
important it is.
I'm sorry. And I think that even before we get to HIV, like trying to remove the stigma from just STIs in general,
Sure.
right?
Mm-hmm.
You're not dirty, right?
Mm-mm.
If you contract an STI, right?
Mm-hmm.
It doesn't mean anything about your character, but we have to remove that stigma before
Mm-hmm.
we can start even having those conversations around HIV prevention,
Mm-hmm.
right? Yeah, they
Mm-hmm.
can you can slide those in there,
Good.
but like let's talk about the other ones before we get to the big one,
Right.
right?
Right.
So
Right.
because we know that there are very specific things that you have to be doing
Mm-hmm.
in order for HIV to be transmitted,
Right.
right?
Right.
So
Right. And the first of that is you have to talk about the sex. So you
mhm,
got to do that to get this. Is in one of the places, one of the ways. So it's comfort. And so you have to take the mantle, right? We're passing the baton and start running with it and creating this movement on Howard University's campus.
Do my
You
best.
know, and it's hard work, and you got to recruit, right? So it's not you, I'm not because campus is a little large, just a little, and so you have to recruit some folks, some like-minded individuals that you know have the same concern and desire to save the lives of young Black folks.
mhm. So before we close, what advice would you have for a community leader to raise awareness and change the culture around HIV within the Shaw Howard community?
I'm going to talk about faith communities. People of color are faithful people, and we end up in some place of worship, a multitude. And there's a lot of power in our churches and our faith communities, and a lot of good messaging can come out of there. I remember one time I was asked to speak at a mosque, at a masjid, and the woman that called me, I always ask what I can say, what I can't say, all the time. What can I say? Tell me what my parameters are. I'm so I can find a way to cross the line, like because that's what it is. You tell me what I can say, what I can't say, because here's what I know needs to be said. And this woman said to me, under no circumstances, we're Muslim and you can't talk about condom use and bring condoms. I was like, huh, it's going to be interesting. But she said, and this is what I heard, I can't bring it up. Okay. So I'm going to make sure that when I ask the audience a question, that the answer is condom use. She said, I can't bring it up. She did not say that could not be the answer. See how I'm going to try to find a side door. So the imam was in the audience as well. And I was like, ooh, you're going to have to be really crafty. And the imams, someone, I positioned the question and the answer was condoms, right? I didn't bring it up. I asked the question. And the imam said, aren't there different types of condoms? Oh, sir? Oh, yes. Yes, there are. There are several types of condoms. Now I can tell you about them. And then he said to me, do you have any? This is the imam, the head of the church, the head of the mosque. Sir, I was told that I cannot bring condoms and penis models into the masjid. And he said to me, I understand. You probably were told that. But if my flock is dead, who do I preach to?
Mhm.
So I need to change a couple of things and shift the conversations that we have so that my flock lives so I can teach. And that is it, right? How do I get to faith communities and talk to leaders in the faith communities around how do we ensure the safety and well-being of your flock so that your flock lives? And that's most places, right? That just shift the audience. It's not flock, it's students. It's not students. It's not, you know what I mean? But that's that's the overarching message is to break down the barrier and the stigma. People are contracting HIV. Here's the rate that it's happening. What is it that we need to do to ensure that your flock, insert word, lives? And so we have to, shift that messaging and target the message so that it reaches the people that we want it to reach.
Verona, thank you. Do you have any final questions that you'd like to ask Dr. Howard before we close?
I didn't have any more questions, but I did want to say I really appreciated like every single anecdote really helped to like take me on the journey of what the answer to the question was and help me see it very visually in a way that like I'm gonna remember and I could like share this information with other people very easily.
Good. Thank you. That's it. It's the sharing of the information. I think that, we are in a space where we don't feel comfortable, sharing information. I share what I have and I take what is given and I ask questions. And sometimes my questions that I ask, like I look at my daughters and they're like,
Yeah.
and I say to them, you do know I ask everybody the same type of questions, right? I'm not just asking this because I'm your mother. I ask and they're like, we know.
Mhm.
Because the answer and the information that we share may save your life and may save someone else's life. And that's important. And that's why I do the work.
So we've come full circle because my initial question to you was, why is it that you do this work? So thank you very much, Dr. Howard and Verona, for spending this time with me. And if you enjoyed this episode, please tune into other podcast series that we have covering topics that cover things like stigma, trauma, and health disparities that impact all of us, and also PrEP and HIV prevention. So I'd like to thank you all and have a wonderful remainder of the day.
Thank you.